If you're prepping for exams, maybe getting ready for a doctor's visit, or you just want to get a real handle on one of the biggest health topics out there, you are in exactly the right place.
You really are.
Today, we are doing a deep dive into hypertension.
Yeah, and think of this as a critical study session. Our whole mission today is to take this really dense topic, the entire system of blood pressure regulation, and just break it down into crystal clear
So
concepts.
from the tiny mechanics all the way up to the clinic.
Exactly. We want you to actually see the plumbing, the wiring, all the control systems right in your mind's eye.
So let's start with a really simple definition. What exactly is hypertension?
At its core, it's the excessive force of blood flowing through your arteries. Simple as that.
And the reason we're focusing on this, the reason it's so important, is because it's called the silent killer.
And for good reason. You usually don't feel it. You don't know you have it until, the damage starts to become serious.
And the stats are, well, they're pretty sobering.
They're a real call to action. Hypertension affects nearly 45% of adults in the U.S. That's, over 100 million people?
Over 100 million, but here's the number that really gets me, the one that defines the challenge. 71% of people who are diagnosed with it do not have their blood pressure under control.
It's staggering. It's not just a medical issue at that point. It's a huge management problem for our whole society.
Right.
So our goal today is clear. We're going to walk through the basic physiology, we'll identify the risk factors, guide you through a proper diagnosis, and then get into the treatment strategies, especially how the different medications work inside these systems.
Okay, let's do it. Where do we begin?
Let's start at the very, very beginning with the physics of pressure.
All right, let's unpack the core formula that governs, well, everything in this topic. Blood pressure is the result of two main things multiplied together.
Right. It's cardiac output, which we call CO, times systemic vascular resistance, or SVR.
CO times SVR.
That's it. CO is how much blood your heart pumps out per minute. Think of it as the pump's efficiency. And SVR is the resistance that blood meets as it flows through the vessels.
The state of the pipes, basically.
The pump and the pipes.
Yeah.
You make the pump work harder, or you narrow the pipes, the pressure just has to go up.
Okay, so let's dig into the pump first. Cardiac output. You said it's influenced by three functions of the heart.
Yep. And there's some medical jargon here, but we can make it simple. First is heart rate or chronotropy. That's just how fast the heart is beating, your speed dial.
Got it.
Second is contractility or inotropy. That's how hard the heart squeezes. Is it a gentle push or a powerful shove? A stronger squeeze moves more blood.
Which increases the CO.
Exactly. And third is conductivity or dromotropy. That's how fast the electrical signal travels through the heart. Good wiring means the pump works smoothly.
All right, so that's the pump. Now, the pipes, SVR.
This is almost all about the diameter of your blood vessels, specifically the little ones, the arterioles.
Okay, walk me through that.
Imagine a garden hose. If the pump your heart is running steady, and you put your thumb over the end of the hose,
You're narrowing the opening.
you're narrowing the pipe. You've just massively increased the SVR, and the water pressure behind your thumb goes way up.
That is a perfect visual. And okay, this feels like one of those key takeaway moments, a real NCLEX alert.
Absolutely.
Yeah.
If you remember one thing, it's this. If anything causes CO to increase.
Like a faster heart rate or a stronger squeeze.
Right. Or if SVR increases, meaning the vessels constrict.
The blood pressure goes up.
It has to. And hypertension is basically when the body's control systems fail to keep that balance in check day after day.
Speaking of control systems, let's get into how the body tries to regulate all this.
Okay, so the fastest one, the immediate responder, is the sympathetic nervous system, the SNS.
The fight or flight system.
Exactly. Driven by adrenaline and norepinephrine. It works almost instantly through these tiny receptors on the blood vessels.
Let's focus on the main ones, the alpha-1 adrenergic receptors. Those are the constrictors, right?
You got it. When adrenaline hits them, they tell the smooth muscles in the vessels to tighten up. That increases SVR and boosts your BP. It's the body's panic button.
But then there are others that do the opposite.
Right, you have the beta-2 adrenergic receptors, which actually cause relaxation or vasodilation. But the really clever part is the alpha-2 adrenergic receptors. They're like an internal brake.
How so?
They actually block the release of norepinephrine. So activating them lowers your blood pressure by telling the SNS to just stand down.
So the SNS is for immediate changes. What about the long game?
For long-term control, we have to look at the kidneys. This is the renal control panel, specifically the renin-angiotensin-aldosterone system.
RAAS.
RAAS. This system kicks in when the kidneys sense that blood flow or pressure is too low. It's a survival mechanism designed to hold on to fluid.
And it's a cascade, right? A series of steps.
It is, and it's so important to know them. So
Yeah.
step 1, BP drops, and the kidney releases an enzyme called renin.
Okay, renin's out.
Renin then finds a protein from the liver called angiotensinogen and converts it into angiotensin I.
Which is still inactive at this point.
Totally inactive. But then angiotensin flows through the blood and hits the magic enzyme, ACE, angiotensin converting enzyme.
And ACE turns it into the active form.
Angiotensin II. And this molecule is the star of the show. It's incredibly powerful.
What does it do?
2 big things. First, it is a potent, immediate vasoconstrictor. It squeezes those pipes hard, cranking up SVR instantly.
And the second thing?
Second, it tells the adrenal gland to release aldosterone. Aldosterone goes to the kidneys and says, hold on to sodium.
And water always follows salt.
Always. So you retain sodium in water, which increases your blood volume. More volume means higher cardiac output and, boom, higher blood pressure.
It's a brilliant system for survival, but if you already have high blood pressure, it's just making things worse.
Exactly. But the body does have a way to fight back a little. It has natriuretic peptides, AMP, BNP.
Right. These are released when the heart muscle stretches too much from high volume.
Precisely. And they go to the kidneys with the opposite message of RAAS. They say, we are overloaded. Get rid of sodium and water now. That helps lower the pressure.
So cool. Okay, what about the really local regulators? Right there in the blood vessels.
Yep. You have natural vasodilators, the openers like prostaglandins, and famously nitric oxide.
Nitric oxide is fascinating.
It really is. It's made by the lining of your vessels, the endothelium, and it tells the muscle around the vessel to relax. That's why exercise and healthy diets are so good. They boost your natural nitric oxide production.
So you have openers. You must have local squeezers, too.
You do. A big one is endothelin. And watching over all of this are the baroreceptors, tiny pressure sensors in your major arteries.
And they're just detecting stretch.
All day long.
Eh.
If they stretch too much from high pressure, they tell the SNS to calm down. If pressure drops and they don't feel enough stretch, they activate the SNS. They're your body's cruise control.
It's such a complex, interconnected system, but for millions of people, it starts to fail.
It does. And that brings us to the 2 main types of hypertension.
Right.
The vast majority of cases, we're talking about 90%, is primary or essential hypertension.
Which basically means we don't know the exact cause.
Exactly. It's idiopathic. It's not one thing. It's a complex failure of the system over time, linked to things like age, genetics, and altered endothelial function.
What does altered endothelial function really mean?
It means that smooth, healthy lining of your blood vessels isn't working right. It's not making enough of the good stuff like nitric oxide, and maybe it's making too much of the bad stuff like endothelin. The pipes just get stiff and resistant.
And that's the 90%. What about the other 10?
That's secondary hypertension. And here, there is a direct, identifiable cause.
Like what?
It could be kidney disease, an endocrine disorder, certain drugs, even something like obstructive sleep apnea. The good news here is, if you can fix the underlying problem, the high blood pressure often goes away.
Okay, let's nail down the risk factors. We can split them into 2 camps, right? Modifiable and non-modifiable.
Yep. Non-modifiable are the things you can't change. Your age BP tends to rise as we get older, your genetics, and your ethnicity.
And ethnicity is a really important clinical factor here.
It is. Black individuals have the highest rates of hypertension and related deaths, and often need different initial drug therapies. Gender plays a role too. Men tend to get it younger, but after age 64, women have a higher prevalence.
Wait, now for the modifiable factors, the ones you, the listener, can actually do something about.
This is where the power is. We're talking about obesity, sedentary lifestyle, diabetes, chronic stress, high cholesterol, alcohol, smoking, and the big one, high salt intake.
Let's connect that back. Salt makes your body hold on to water.
Which increases your blood volume, which increases your cardiac output. It's a direct line from your diet right back to that core BP equation.
So diagnosis. This seems straightforward, but it's actually really easy to get wrong.
It is. And accuracy is everything. So here's another NCLEX alert moment for you. A diagnosis of hypertension requires 2 or more high readings on 2 separate occasions.
One high reading in the clinic doesn't count.
It's just an observation.
Yeah.
And you have to prep for the reading, no smoking, caffeine, or exercise for 30 minutes before.
Yeah.
Sit quietly for 5 minutes, don't talk, feet flat on the floor.
And the cuff size is critical.
So critical. Arm at heart level.
Yeah.
You should measure both arms the first time.
Why both?
Because you use the arm with the highest reading for all your future monitoring. That's the standard.
Once you have those accurate numbers, what do they mean?
We use a classification table. Normal is less than 120 over 80. Elevated is 120 to 129 over less than 80. Stage 1, hypertension starts at 130 over 80.
And stage 2?
Stage 2 is 140 or higher or 90 or higher.
Okay. Before we hit treatment, can we quickly touch on MAP, mean arterial pressure?
Yes, great point. So systolic and diastolic are the high and low points. MAP is the average pressure that's actually getting to your organs.
So it's a measure of perfusion.
Exactly.
Yeah.
It's arguably more important clinically. The formula is 2 times the diastolic plus the systolic, all of that divided by 3.
Got it. Okay, let's talk about management, the two-pronged attack.
Lifestyle modification and medication. And lifestyle isn't just a suggestion. It is the absolute foundation of all treatment.
Give me an example.
Weight reduction. For every kilogram you lose, that's about 2.2 pounds, your systolic blood pressure drops by about 1 millimeter of mercury. It's a direct link.
And activity.
150 minutes of moderate activity a week. It helps your endothelium. It manages stress. It's huge.
Smoking has to go.
Non-negotiable. Nicotine is an immediate vasoconstrictor. It squeezes your pipes instantly. Quitting drops your cardiovascular risk so much in just 1 year.
And diet, specifically the DASH diet.
Dietary approaches to stop hypertension. It's all about fruits, veggies, whole grains, lean protein. It's naturally high in things like potassium and magnesium that help lower blood pressure.
Which brings us back to salt. Let's hit that one more time.
Okay, another big NCLEX alert. The general rule is less than 2,300 milligrams a day. But for anyone with hypertension, kidney disease, or diabetes, the goal is much lower.
Hello.
Less than 1,500 milligrams a day. That directly fights the volume retention we talked about with aldosterone.
So when lifestyle changes aren't quite enough, we bring in the medications.
We do. And we should think about the 4 major classes in terms of how they hack into those control systems we just broke down.
Let's start with the first line choice, usually diuretics.
Yep, thiazides, like hydrochlorothiazide. The mechanism is beautiful in its simplicity. They just block sodium from being reabsorbed in a part of the kidney.
So the salt stays in the urine?
The salt stays, water follows it, and you pee out the excess volume. Less volume means lower cardiac output, which means lower blood pressure.
What's the main thing to watch out for?
Electrolytes, specifically low potassium or hypokalemia, and you have to monitor kidney function. Also, and this is critical, they are generally not safe for pregnant people.
Okay, class 2. Let's go back to RAAS and talk about ACE inhibitors.
The prepols, lisinopril is the classic one.
Yeah.
These drugs block that enzyme, ACE.
The one that converts angiotensin first to the super powerful angiotensin the second?
That's the one. So if you block ACE, you stop making the vasoconstrictor. That means less squeeze on the pipes, so lower SVR, and less aldosterone, so less volume. They are really effective.
But they have that one really famous side effect.
The dry, hacking cough. It happens because ACE also breaks down another substance called bradykinin. When you block ACE, bradykinin builds up and can irritate the lungs.
And the really serious, though rare, side effect?
Angioedema, swelling of the face, lips, airway. It's a medical emergency. And just like diuretics, ACE inhibitors are teratogenic, absolutely contraindicated in pregnancy.
What about drug interactions?
Yeah. NSAIDs, like ibuprofen, make them less effective. NSAIDs block prostaglandins, which are natural vasodilators. So you're kind of fighting against what the ACE inhibitor is trying to do.
So if a patient gets that cough, where do you go next?
You often move to the third class, angiotensin II, receptor blockers, or ARBs, the dineuretians like losartan.
And how are these different?
They're clever. They don't stop you from making angiotensin II. They just block the receptors it's trying to connect to. It's like unplugging the phone so the call can't get through.
So you got the same benefit-less squeeze, less volume, but without that bradykinin cough.
Exactly. But they carry the same serious warnings, risk of high potassium, and they're also teratogenic.
Okay, fourth and final major class, calcium channel blockers, CCBs.
Right. So muscle cells, whether in your heart or your blood vessels, need calcium to enter them in order to contract. CCBs just block the channel so the calcium can't get in.
And no calcium means?
No contraction, or at least less of it. This leads to vasodilation in the vessels, and it can decrease the heart rate and how hard the heart squeezes.
And there are 2 types of these, right?
We split them into 2 groups. The dihydropyridines, like amlodipine, mostly work on the peripheral blood vessels. They're all about opening up the pipes to lower SVR.
And the others?
The non-dihydropyridines, like diltiazem and verapamil, they work more on the heart muscle itself. They slow the heart rate and reduce the force of the contraction. They're focused more on the pump.
This all brings us to why we care so much, why we treat this so aggressively. It's the end organ damage.
And it happens silently. It's happening long before the patient ever feels a single symptom. That's the scary part.
The constant high pressure just wears things out.
It damages tissues everywhere. In the heart, it makes the left ventricle get thick and overworked, which leads to heart failure. It speeds up coronary artery disease.
In the brain, it's the #1 risk factor for a stroke.
It is. It damages the vessels themselves, leading to aneurysms and atherosclerosis. The kidneys take a massive hit, which can lead to chronic kidney disease and the need for dialysis.
Even your eyes.
Even the tiny, delicate vessels in your eyes can get damaged, causing retinal problems.
So when we're talking about care, it's all about assessment and compliance.
100%. The assessment has to be thorough lifestyle, diet, other drugs. And we have to be aware of white coat syndrome, right? When the pressure's high just because they're nervous in the clinic.
We also have to think about different age groups.
Absolutely. For older adults, the big challenges are often practical. Managing multiple medications, the cost, and a big one is the risk of orthostatic hypotension,
That sudden drop in blood pressure when you stand up.
which can cause falls. It's a huge safety issue.
And what about kids? It's sad, but this is a growing problem.
It really is. In older kids and teens, it's often primary hypertension linked to obesity, just like in adults. In younger kids, you're more likely to see secondary hypertension caused by a kidney or heart problem.
But at the end of the day, for every age, the biggest hurdle is compliance, isn't it?
It's the single biggest problem because the patient feels fine. So our job is education. They need to know the name of every drug, why they're taking it, and what side effects to look for.
And being really clear about the rules?
So clear. Never double a dose.
Yeah.
Don't skip a dose. And critically, never ever stop taking the medication suddenly. That can cause a dangerous rebound of high blood pressure.
It's really about forming a partnership.
That's the only way it works.
Wow, we have covered a ton of ground today. We defined hypertension. We broke down that core equation of the pump and the pipes.
We explored the 4 big control systems, the SNS, RAAS, the peptides, and the local regulators. And then we tied it all to the treatment strategies of lifestyle and medication.
Understanding hypertension is really about understanding this delicate dance between volume, resistance, and contractility. But the real challenge is that success depends almost entirely on the patient sticking with it long term.
And that, I think, brings us to the final, really provocative question. The thing that frames the true societal challenge here. If getting to a goal, blood pressure, depends so much on compliance, on having access to healthy food, on being able to afford your meds, how do we, as health advocates, account for the huge impact of social determinants of health?
That's the real question, isn't it? If your socioeconomic status, your stress level, your housing situation, if those things are barriers to eating a low-salt diet or picking up your prescription,
Then how can the system really provide the support that's needed for the millions of people whose hypertension is still tragically uncontrolled?
it's a problem that requires solutions that go way beyond the doctor's office.
It really does. We hope this deep dive has given you the foundation you need to think through this incredibly complex and important topic.
Thank you for joining us. Until next time, keep learning.